do is let me go over the questions. And the first question was schizophrenia is associated with NMDA blank, and the correct answer is hypofunction. Correct answer is A. Thank you, Aiden. Second question, hallucinations would be a blank symptom of schizophrenia. Correct answer is A, would be positive. And then the third question, this is the one I told you it could potentially be controversial the way I wrote it. So in schizophrenia, there is an activity of dopamine. So typically we would say that getting back, you could argue that increase, which we do see in one transmitter, so excuse me, in one pathway. So that would be there, and it could be, if you said decrease, that would be in the other pathway. So the more, this is the way the question is worded is difficult in the sense that you could argue an answer for both. From a therapeutic standpoint, the biggest issue is the increase in there. So this would be, I mean, basically a better question, one that I would ask you, be more likely to ask you on the exam would be something like an increase in a specific pathway or a decrease in a specific pathway, so that you would have to know that. So again, this gets back to the thing that I asked you to do was to look back over and see if you followed the pathways and if there was anything that was confusing about those. When I was going through in this, we didn't really talk about the pathways. We, when I was going through it, when I was taking school, we didn't talk about the specific pathways. We talked about basically that it was a disease of increased activity, dopaminergic activity, and we talked about primarily the mesolimbic, the tuberofundibular and the nigrostriatal pathways. So when I was going through, basically most of the drugs acted to block dopamine receptors, and they worked mainly on the positive symptoms, and we just simply said there was not much of an effect on the negative symptoms. And then the other thing we did was we said, and by the way, in order to get this efficacy, there's a good chance that you're going to block the dopamine receptors in the nigrostriatal pathway and give you EPS and get galactorrhea due to the tuberofundibular pathway. So that's the way it was discussed. But you will see as we talk about this afternoon, and then more tomorrow, is we've now involved with the new drugs a separate action, which creates another way for us to think about it. Okay? All right. Now, the other thing I just wanted to mention, I hope the virus, again, the little video that I had Aiden put up was not in neuronal tissue, but what it was showing you how a virus will get inside a cell, use some of the cells on biochemical mechanisms, and basically sort of take over the cell. And this is, the cell can become dysfunctional, the cell can, but for a while, the virus could get in there and then make an alteration. So again, what I showed you was, or sent that video, was really just to show you in general what a virus does by getting into the cell. Okay? All right, does anybody have a question or anything that, what I'm gonna do is I think we're gonna move forward, and I'm gonna talk about these other transmitters. We're gonna talk about serotonin, we'll talk about the NMDA, and then you will see we will revisit the dopamine pathways, okay? All right, so let's move to the serotonin component. And with the serotonin issue, again, what people like to do when they were first working on this and so forth, their biggest thing that they like to try to do is just to focus on one transmitter system. Why did they do that? Is because it made things somewhat simpler in the sense that you were literally looking at, you're not looking at all the other different pathways and that sort of thing. also remember that when we started doing these studies, one of the big things that came about was that um, a lot of our analysis for looking at transmitters, we basically were taking like whole brains in animal studies, or we would take a section of the brain. We might take the brain stem or the cortex and grind it up and see if there were changes in transmitters. So if you had a change in one way in one transmitter and one in another a change went a different way, you may not pick up a difference there. So it was one of those things which was difficult to separate out. But then we became where that we could we could use cannulas to go in and sample small areas, or we could do punch biopsies, if you will, not well post-mortem. So what we would do is we'd go in, section the brain, and then take a specific structure out. So we started seeing differences, plus our ability to detect smaller smaller amounts of a transmitter got better. So for a while, all we would measure would be primarily metabolites because they were in abundance. But now we've got where that we can take relatively small areas of the brain. We can even do things where that we will, even in rats and even mice, we can go down and we sort of perfuse the area so we can pick up some things that are occurring. So our technology and analytical techniques have actually improved, which allows us to get a better situation. I know when I was doing my postdoctoral work, we were doing putting cannulas. We were using dogs and cats, but we were putting cannulas like in the third ventricle and the fourth ventricle, and we were doing manipulations to see that there were different changes in transmitters by measuring the cerebral spinal fluid, and we thought that was pretty unique from a standpoint. But we've also got some of the imaging studies, which have become, as we've improved our imaging studies, it has become really amazing with some of the things that we can see. So with serotonin, what we do know, I mean, when people saw things like depression, they immediately started thinking, well, serotonin has to be involved. And there have been different studies, both in animals and then also some studies in humans that have suggested that there have functional alterations. I think there's been some studies where they've measured cerebral spinal fluid and looked at serotonin or serotonin metabolites. And then, so when people started thinking about multiple transmitters, one of the things that emerged was that it was recognized that the serotonin system can have an impact on the dopaminergic system. And so this became a central component that we started focusing on, is the fact that we do know that serotonin impinges on dopaminergic neurons. And with that being known, basically what that tells us is that changes in serotonin could impact dopamine. So here's a good example, and this is going, excuse me, and this is going to be an important thing for us to know to understand how the new drugs are basically working. So what we know is we know that a lot of times the serotonergic neurons, if you ask people to tell you where an area of serotonin is, they'll talk about the raphe nucleus. So what we find is the yellow neuron here at the bottom is a serotonin neuron. And up here is we have a dopaminergic neuron, okay? So here we have the serotonin neuron in the raphe nucleus, and we have a dopaminergic neuron in the substantia nigra. So one of the things that we see is that on this dopaminergic neuron, there is a serotonin 2A receptor, okay? Which means that when this serotonin neuron in the raphe nucleus actually releases serotonin, what it's going to do is it's going to stimulate that serotonin 2A receptor, which is up here close to the cell body. We also know there's a serotonin 2A receptor on the presynaptic terminal up here of the dopaminergic neuron. So here we have a neuroanatomical, but a functional interaction or um, basically communication that's occurring where that the serotonin neuron can actually affect the dopaminergic neuron. So let's see what happens here. Here's another situation. So here's a key point to be thinking about. Again, same situation is that we have, so if you look at these slides, it's in they're sort of ordered sequentially. So this is demonstrating, number one is demonstrating that there is a relationship. So look at the panel number 2, which is on the next slide. And what we see here is that, again, this is a situation, I mean, it's showing the same relationship and showing the same relationship in 3. So what we find is this is really explaining them. Serotonin interacts with the serotonin 2A receptor. We know that the 2A receptor basically is going to be stimulated by serotonin. And that is at the postsynaptic level. So postsynaptic is across the synapse. So we see across the synapse here is, a presynaptic is the serotonin here. Postsynaptic is the receptors on the dopamine neuron. And so the interaction is going to occur both at the cell body. So here's the cell body here. Cell body is right here. As you can see, the cell body is there. And we see it at the axonal terminals. So what happens is that serotonin can interact with these serotonin receptors to basically inhibit the release of dopamine. Okay, think back before lunch when we were talking, is one of the issues that we run into is that basically what we have here is a situation where in one system we have a dopaminergic elevation or increased activity, hyperdopaminergia, and another one we have a hyperdopaminergia. So with this one here is, this is one issue which would inhibit release of dopamine, so it would reduce that hyperdopaminergia. Or the thing is, we can find that serotonin 2 antagonists can cause more release of dopamine, because if these, when they're stimulating it, they're basically inhibiting it. But if we block that, so we put an antagonist here, what that's going to do is it's going to cause release of more dopamine. Okay? So depending on the pathway, we find that serotonin 2A receptor and dopamine 2 antagonism can cause different effects in different dopamine pathways. So think about it, just put this in your mind right now. So the idea is that we have 2 dopamine pathways, one mediating positive, one mediating negative. One has got a hyperdopaminergic system, the other has got a hypo. So one of the things is that, is this a possibility for addressing the different situations that we have in those pathways? Short answer is yes. We're going to put that into perspective when we see. So the conventional drugs, the old phenothiazines, they were primarily dopaminergic antagonists. They blocked the dopamine receptor. So if we had too much dopamine, that was good. It blocked the effects of the dopamine. But it wasn't good if we had a decrease in dopamine. That just made that worse, or wouldn't have an effect. By adding in the serotonergic component, what we now have is the possibility of affecting the dopaminergic in an opposite way. And in fact, what you see is the atypical, the new agents, they are D2 antagonists, similar to the older agents, but they bring to the table 5-HT2A antagonism. So that is, you will see, is going to be the real big difference. This is why that these agents are preferred, because they have the ability to potentially elevate that hypodopaminergic component. By adding a serotonin antagonist property there, it's going to give us a chance for basically addressing that hypodopaminergic component. So what we find is in the mesolimbic pathway, we have dopaminergic hyperactivity, and that's associated with positive symptoms. So what we want to do is we want to decrease dopamine. Okay. So by decreasing dopamine, that should help with the positive symptoms. Okay. Now, what I've done is you see sort of whited out so that I'm talking about these other pathways, which is the previous slide, and this was just to emphasize that by the dopamine antagonism gets rid of the hyperactivity, but we still have the issue about we've got a hypo activity in another pathway, the mesocortical pathway. And so we're going to have to address that through a slightly different mechanism, and that's where we bring in the serotonin. All right, we'll come back to that. So let's go over a few of the other transmitters. Acetylcholine has been brought in. We've mentioned norepinephrine. H1, the histaminergic system has been suggested. We've seen GABA, glycine, glutamate, others have been all identified. And again, when you look at it, is that, for example, sometimes you find that these transmitters are being either inhibitory, excitatory, and people have tried to make a case for it. But probably, and as we mentioned earlier this morning, we said that there was some NMDA hypofunction. So that was a target. So let's look at this NMDA. So just to point out, we have NMDA receptors. You can see them. I hope you guys can see my pen here. That's there. Here's the NMDA receptors. They're on what is known as a chandelier cell. And what we have is glutamate basically is being released. And when glutamate is released, they act on the chandelier cells to increase the release of GABA. And so that's excitatory on the chandelier cells, which causes the release of GABA. The GABA will then act on the GABA A receptor, which are on the pyramidal neurons, and that can then have an effect on glutamate. So what we find is that these GABAergic interneurons, so this would be this one, here's the interneuron here, these chandelier cells, excuse me. So what happens is if these NMDA receptors are impaired, so in other words, they're either hypofunctional, maybe they're even fewer receptors or whatever. The idea is that if we can't, even though glutamate comes in there, we have an impairment or a hypofunction of these NMDA receptors. So what that means is that there's less stimulation of this chandelier cell, meaning there's less release of GABA. And so the GABA is not released. And so what that does is basically that causes an increased release of glutamate by this pyramidal neuron, which can then activate AMPA receptors. So again, this is a sort of a brake, if you will. Puts the brakes on, and what happens is if these receptors here become impaired, then the GABA, the inhibitory transmitter, is decreased. And when it's decreased, one of the things that happens is that allows more AMPA to be released. So the idea would be is if we could stimulate these receptors, that would potentially increase the GABA release. Now let's go to the next slide, which sort of talks about this situation here. So what we have here in the cortex, that there's glutamine and glutamate that's cycling between the neurons and the astrocytes. So in schizophrenia, what appears to happen is that that for some reason this glutamine-glutamate cycle is impaired. So what will happen here is that these astrocytes, they have a hypoglutamate glutaminergia that will cause the basal ganglia and produce that will evoke basal ganglia hyperdopaminergia. Okay, that can then have a decreased inhibition on the GABAergic neuron. So the net effect is when we get sensory input, that we get an overload because the brakes, these inhibitory pathways, are impaired. So when the sensory input comes in, basically you get an overload, and that is what has been suggested that causes the psychosis, is that the things that would normally sort of put the brakes on, this hypoglutaminergia and the hyperdopaminergia and so forth, what you have is really a dysfunction. So with that dysfunction, the signals that come in are much more intense. They will result in a much greater overload of the cortex, and then you get psychosis. So this this interaction between the astrocyte and the neuron that was mentioned back here when we're talking about this right here is what is shown here on the next slide. Excuse me, there. So basically here we have the astrocyte. You see that over here, this is the astrocyte. And then basically here's the neuron is on the right side. So what you have here is you got in the neuron, you got glucose, which comes in, goes to pyruvate, that goes to the TCA cycle, the tricarboxylic acid cycle. And basically this is one of the ways that we form GABA and glutamate, okay? So GAD is the glutamate decarboxylase, and then this is so here we are having glutamate that's being formed here, okay? Now, on the astrocyte, we start off with glucose, but it can also pick up acetate, goes to pyruvate, tricarboxylic acid, we get basically glutamate formed, and then that can go to glutamine, and the glutamate will also be picked up through here. So what happens here is that this is an interaction that sort of controls glutamate and glutamine and GABA. In schizophrenia, there seems to be a problem where that this metabolic pathway and interaction between the neuron and the astrocyte seems to be impaired, and that can create dysfunction. Now, remember this morning we talked about there can be some problems with the neuronal, different things can affect this. So let's take a look. When we see, for example, there have been postmortem examination of brain tissue from people that are schizophrenics and normals. So if you look to your left on this slide, this is some pyramidal neurons, and this is what would be considered normal. So basically what we find is when we compare these to schizophrenics, so first of all, what we found is the somal volume. So this would be the somal volume in here is reduced in schizophrenics. So they have a smaller somal volume. The neurons are smaller, okay? So that's one thing. Another thing we see is that compared to the normal is these spines, the spine density. So we can see, these are all spines that are coming off these little branches, think about them. And then we also have these little terminals that are coming out here. So notice over here is that the spine density is, and as well as the terminals are much smaller. See, we got all these terminals and spines here and here. And if we compare them, see how sparse they are here and even here. So what that tells us is basically that some of the connections, and also we see that with those decreased spine density, we see fewer terminals. And the way they determine is they measure chemicals that would be present in the presynaptic terminal, and those are reduced. So that's another thing. And then we see another thing is that the dendrites are shorter. So um, in the compared to the normal, the length of the dendrites are much smaller. So we see some obvious neuronal changes that are present in schizophrenics that are suggestive of damage to the neurons and dysfunction of the neurons. And when you look at all these changes that occur in the looking at the neurons specifically, what it does suggest is, and again, these are all postmortem. And anytime we're looking at postmortem tissue, we always have to consider, there could be some postmortem changes and so forth. But remember, we're comparing them to postmortem. The normals are postmortem also. But the net effect is that we see in schizophrenics there is evidence that there is damage to the neuronal circuitry. If there's damage to the circuitry, it has to have an impact on, it's easy to sort of understand if we have a hypodopaminergic area, it may be due to a reduction in those issues. But think about this, is that the hyperdopaminergic could also be due to this because it could be that there's a reduction in, for example, serotonergic activity, and that could be affecting things also. There have been a number of studies to try to determine what causes this. And this is taken from a mitochondrial, are taken from tissues describing how in a cell, and this would include a neuron, that when the mitochondria, remember the mitochondria are basically the respiration of the cells. And also the endoplasmic reticulum is involved in making a lot of the proteins. But this is basically demonstrating that what happens here is that when the mitochondria and the endoplasmic reticulum get stressed and get excessively stressed, that what that can do is it can actually activate what we refer to as a death receptor pathway. And so remember, one thing is we have a lot of cells that when they wear out, they die. And that usually they die, a lot of times the cells, as they start getting worn out, they will go into what is referred to as apoptosis. You have to think about some time ago about the apoptosis, because basically with apoptosis, that is programmed cell death. So it's a way our body sort of, as our cells wear out, then basically the cells will be destroyed and we replace them. But one of the things that we realized is that in some disease states, what actually has occurred is that this apoptotic pathway may be activated. And when it gets activated too soon, then basically the cells may die prematurely. And so one of the things that can happen here is that when the mitochondria and the endoplasmic reticulum actually get stressed, it may be to the point that the cell activates the death receptor pathway and the cell dies prematurely. And so this goes through all of the molecular biology, which I'm not interested that you go into, other than what I want you to be aware of is basically that these situations may be whatever the etiology is, whether it's genetically predisposed, whether it's stressors, whether it's a virus, but any of those things could potentially activate or stress the mitochondria and the endoplasmic reticulum, which means that activates this death receptor pathway and the cells die. The net effect of this is going to be, this is just another diagram showing it. So here we have that the mitochondria get stressed. They activate this pathway, which basically results in, for example, in the innards of the cell, the DNA and the other components basically break down. That can occur due to stress with the mitochondria. Some people have argued that some stress may actually activate up here. They call it an extrinsic pathway, where that a substance, tumor necrosis factor alpha, which is TNF alpha, can sometimes stimulate the cell to, it recognizes the cell as being either foreign or damaged. So the TNF alpha will cause the cell to break down and die prematurely. Or the other thing that can happen is that inflammation can activate and the cell is recognized as being damaged. So these things here, there are mechanisms that may kick in. This is part of that autoimmune system too, is that sometimes the inflammatory condition is the body attacks the cells. So this has all been sort of put together as from a molecular biology to try to describe how some of these cells may die. The net effect is what you see is something like this, is that here you have this pyramidal neuron, and it's got all of these different things that are synapsing on its dendrites and so forth. And so if we move to, so we're going to enlarge this area. So here you have the, you have these presynaptic terminals that are here. And then what happens is that one of these death receptor pathways gets activated in the neuron for whatever reason. I mean, it could be secondary to stress, it could be secondary to a virus, secondary to some sort of inflammation, some genetic predisposition. So notice what's happening here is in the second frame here is that basically this pathway gets activated and this portion of the neuron dies off. And then we find that, so now we're left with a reduction in the number of spines and the number of presynaptic terminals. Going back a couple of slides, remember we talked about this. This would be one way that we get this type of situation, is that this activation of this death pathway by whatever mechanism or whatever stimulus would result in the reduction in spines and so forth. So again, there's been a lot of information that we're trying to come about to try to understand how this occurs. Ultimately, by understanding this might be a way to give us an idea of maybe how to prevent this from occurring. But right now, we're not, because of the complexity of this, this might tell us what some risk factors would be that would set up for this, such as things like we know about viruses and so forth. But for a treatment standpoint, at this particular point, this may give us information on risk, but from a treatment standpoint, this is not a way that we would, I mean, literally, you would have to try to block the apoptotic pathway, this death receptor, but then you would need to realize that when you do that, it's possible that you're going to interfere with other things. Where is some things that could be interfered with if we were to block this apoptosis? You see anything normal in your body think about anything normal in your body that could potentially be impacted if we blocked the apoptotic pathway? Think about where there's a turnover. So, exactly. All right. So cancer, the tumors or cancer is, I mean, that would be, if we block that, then yeah, that would be another thing. Think about some other things. Rebecca, you sort of touched on it. Oh, there you go, Eddie. So stomach lining, your GI tract has to turn over quite a bit. Red blood cells, your blood cells, your red blood cells are basically, they're getting worn out. But your stomach lining needs to get rid of those. Your skin, think about your skin. We're constantly sloughing off skin and as skin gets damaged, but otherwise that's going to make it very difficult for this to be a target to try to block this. So right now it's giving us an understanding, this type of information is giving us some sort of understanding of how the disease may work. Now, what might be a potential target? would be something that could reinitiate growth of those. You know, so replace that. That's still down the road. All right, make sure you know this, this slide. I've told you this before, a couple of this is probably. So when we look at the symptoms of schizophrenia, we have the positive. You've seen some of these earlier. Okay. Let me get Gerald. Let me read your thing here. The death receptor pathway results in the reduction of the spines, which is bearing on the disease prognosis. In a way, no, it will be, because the idea would be is that ultimately, if we are looking at that there is a dysfunction that is occurring to produce these actions, then you do have, I mean, the death receptor, the fact that it may be, or this death receptor pathway is activated and may prematurely kill some of these neuronal tissues. So from a standpoint, a susceptible individual could possibly be someone who that death receptor pathway seems to be overly active, or maybe exposed to something that would be there. So the issue would be is that could potentially affect the disease prognosis. But at this time of trying to get an estimate of how much is involved and so forth, we just don't have that any right now. So you're right, is that receptor pathway reduces the spines and results in the dysfunction that can occur, and ultimately would affect the prognosis and the symptoms. In other words, you would expect someone in which this death pathway was taking out neurons at a greater rate or in a greater quantity would be at a higher risk for progression of the symptoms. But at this point, I'm not aware of anything that we've got that would be able for us to estimate. I mean, we can do estimations of like hippocampal volume, and we do see some associations with those, but that is sort of a generic, and it's, you know, it's assuming that the reduction in volume may be due to this damage. So we've seen some of these things like this, but it's, so your question is, yes, it would affect the disease prognosis. How much we can actually use it, I don't know. It's just one of those things that at this point, I don't know if we have the technology to get it. Okay. All right. So one of the things that, you know, we've talked about these different symptoms that can occur here. And I sort of think of like the positive symptoms as sort of the more activating type symptoms, if you will. Whereas the negative tend to be more of the withdrawal type, pull in type things. So that's sort of how I tell the pharmacy students to think of it. So one of the things that we recognized was we had both of these classes of symptoms can have significant impacts on the individual. There's no doubt about that. But early on, the problem we ran into with the early drugs was this. They primarily affected the positive symptoms, okay, which means we really didn't mess with the negative symptoms. Some of the things that we would see is that we would treat the positive symptoms, and maybe things like the hallucinations, delusions, and more. You know, one of the big things people always were concerned about with people with schizophrenia, especially with older people and so forth, was really a concern with the agitation, dealing with the agitation. You know, were they able to handle them and things like that? So the idea was that sometimes we would treat them and it would take care of them. And then what you would see is these symptoms would go down. Maybe the hallucinations, the agitation would be there. One of the things we'd see sometimes with the agitation would be they would just try to treat that by using sedatives. But treating these, most of the drugs we had very little effect on the negative symptoms. So one of the things you would see is you would treat the positive symptoms, and then we would see, you know, I don't have depression on here, but sometimes the amotivation and head knee and things like that would be sometimes the blunted affect would be considered depression. So what they would do is be giving them one of the conventional drugs for the positive symptoms, but then as some of the other symptoms emerge, the negative symptoms, then you see them started to treat those with sometimes with stimulants and sometimes with antidepressants. So, but a lot of the first drugs, the problem was all we had was drugs that primarily worked on the positive symptoms. Now, a key point that comes into play is diagnosing correctly. Okay. Here's the things that you guys know about doing a differential diagnosis. Here's the things that you need to think about when somebody comes in that maybe schizophrenia may be a consideration. So one of the things is it substance related? Okay. Now, when I say this, one of the questions is, could it be another drug that they're on? You know that we have a number of drugs. For example, some of the antidepressants can move somebody into mania. We also have, things like stimulants that even though they're being treated therapeutically, we have to consider as to whether the symptoms that they're presenting with could be due to some other substance, and maybe it's prescription or therapeutic component. Things you want to think about is, has there been a recent add on to that drug? Has there been a change in dose? Has there been a alteration in therapy? Maybe you've had multiple drugs going on, and one of the drugs inhibits the metabolism of another, so that when you remove that drug that's inhibiting the metabolism or that's speeding up metabolism or whatever, basically that may want to emerge. So we want to look at, what else are they taking? We want to include things over the counter. We want to include things, supplements. We have to consider substance abuse. Are they abusing anything? That the patient may not be as willing to agree with. And I'm going to show you some drugs in a few minutes that we have to consider. Another thing is this, could this be, again, part of the diagnosis, is this could this be secondary to a mood disorder? Primarily, is it somebody that may be bipolar that was being treated primarily for depression and has got them moved over to mania? We have to consider so those are psychological, psychiatric concerns. Let's look at some other things that may be physical. What conditions could potentially mimic a disorder? Are there any medications that could trigger or mimic or exacerbate the disorder? These are all things that we need to consider in trying to come up with the diagnosis. So medical conditions that can cause psychosis. Adrenal disorders. Those are anything that may alter cortisol, those type of things. Endocrine disorders. Endocrine disorders can include thyroid. It can include the adrenal gland. We see people with, that have Cushing's or Addison's disease, which are adrenal disorders, and those can result in psychological conditions, including psychosis. So we want to check out even alterations in, gonadotropal hormones, estrogens, and testosterone can create a problem. Electrolyte imbalances, magnesium, calcium, phosphate. Another one would be even sodium. We've seen people that can develop conditions when sodium levels are off. Temporal or frontal lobe problems. Has there been a blow to the head? Is there a potential for a cancer or a tumor that may have grown? Wilson's disease, Huntington's chorea, early stages of MS, lupus, porphyria. These are various diseases that, as they emerge, can result in some mental changes with someone. Several of these we can check by just doing a straight physical and or some lab tests. For example, the adrenal disorders, there's like Addison's and Cushing's disease, have pretty characteristic changes. Hyperthyroidism, we see the exophthalmia. We can run cortisol levels. We can pick up thyroid levels. We can pick up all of those. temporal or frontal lobe problems, we're looking for we may want to take a look at any recent head injuries. We may want to look at an EEG. They want to do just, CAT scan to see if there's a tumor or anything like that. So with a lot of these, we can easily rule out many of these. We do have tests and markers that will allow us to rule these other things out. One of the important things is going to be looking at getting a good medication history. And one of the things you got to be careful about is this. One is you need to know what the patient is taking. It's good that you could find out at what time they're taking the medication each day, because we may see a temporal situation. We may be able to see that the psychosis or some of the other things come on at a certain time, and that may correlate with the peak effects that you see with these drugs. Antipsychotics, even though they're antipsychotic, they may produce psychosis. They may produce some of the negative symptoms, or maybe perceived as some of the effects they have could be some of the negative symptoms. Dopaminergic agents, anticholinergics. And when we're talking about anticholinergic drugs, we have to consider there's a number of drugs that may not be truly classified as being anticholinergics, but they may have significant anticholinergic properties. Things like tricyclic antidepressants, for example. That could very well be an issue that we need to, we have to be aware of, okay? Especially if they're taking high doses. The other thing to be aware of with these drugs is sometimes it may be that a person may be mixing up drugs, taking someone else's drugs by mistake. What I've seen is that, so for example, one of these instances I saw is the patients, the husband and wife, they were both getting prescriptions. They were going to one pharmacy. The wife changed to a different pharmacy. The different pharmacy had the prescription bottle was slightly different. And then the husband changed just to make it more convenient. But what happened is, up until that time, the wife knew all of her medications were in the one type of bottle that the pharmacy filled, and her husband's was in a different bottle. And when her husband started going, then she started by mixing up, by taking some of his drugs, because she'd gotten into the mode of just picking up the bottle, what it looked like. So even things like that can occur. Or sometimes when people are putting them, there's a lot of different of these pill packs that people can buy. Sometimes they can be distracted and put the wrong things and maybe pick somebody else's medicines up. Steroids. So we see people, my wife is a good example that she cannot take prednisone. She gets almost psychotic. I mean, that's an exaggeration. That's the way she describes it. But I mean, there is a big difference when if she went on prednisone, it's to the point where that she just does not go on it unless there's the absolute have to and there's no other option, because she just starts feeling, really weird. Also, we could see birth control pills. We've seen things that occurred with testosterone supplements. Things can occur. So steroids and hormones, there's sort of can be an overlap there. Benzodiazepines. How many of you knew that benzodiazepines could cause psychosis? Typically, we think about benzodiazepines as being, used to treat or being sedative type agents. What we actually found is, and I've had physicians, a lot of them, not necessarily, Gupta, it can occur during withdrawal, but there is a paradoxical effect that benzos, I think we mentioned that last time. So when I talked to you about anti-anxiety agents, is some people on benzodiazepines may have a paradoxical effect. So when you, and I didn't call it psychosis when I talked about anxiety, but they can produce, we have had a few individuals that have developed that. barbiturates, and opiates, psychostimulants. Of this group, most people, if I just gave it to them and said, which drugs can cause psychosis, they would pick these drugs. They would say psychostimulants. I think most of them would say potentially steroids. And as far as as you were mentioning, from a standpoint of the during withdrawal, I think a lot of people would say benzos and opiates and barbiturates in particular could cause that. We also see psychosis occurring with some of the cancer chemotherapy agents. A lot of people, when they think of chemotherapy, they think of the chemobrain, and that tends to be a clouding. But we do see sometimes individuals may actually suffer from psychosis and things like that. And let's cover this slide, and then we'll take our afternoon break. There are some herbal medicines that can produce it. Juniper has produced hallucinations. Ma Huang, which is also known as Chinese ephedra, has been known to produce psychosis and mania. We used to see Ma Huang stuck in a lot of products, especially weight loss products and things like that. Ginseng, mania and insomnia has been associated with that. Echinacea, a lot of people this time of year start taking echinacea because of its immune system stimulation, and it has been known to cause CNS stimulation. And St. John's wort can have some enhanced serotonin receptor inhibition or monoamine oxidase activity. A lot of the preparations that we see that contain the juniper, Ma Huang, typically it's not a big concern, but we may see differences when somebody, like for example, I had some Chinese students, Korean students that would bring me some ginseng and would talk about that there was the ginseng that they got was much stronger than what we get in the States. In fact, a lot of them would laugh about the ginseng that we used to get in the States, that it was just like nothing. But one of the things we need to look at is herbal medicine, as we see a lot more people using herbal medicine. And a lot of them, again, like echinacea in particular, would not necessarily flag most people. But these, if the person has started taking these or is up the dose, there's two possibilities with these herbals. One is if they're supplements, there's always a concern with regard to that possibly being a contaminant in there, a prescription drug that has been put in there to make the drug work a little better. And then the other thing is that there can also be some contaminants that could contribute to that too. All right, so let's come back at 1:15. And Aiden, I think I told you I've already sent you the test for the end of the day, but we'll come back at 1:15, and we're going to talk about some more disorders with that produce psychosis. Okay.
Okay, doctor.
To your experiences, we talked about. Let's make sure this. Well, let's go to the next slide there. So the other thing we look at is are there any disorders that have psychotic symptoms? And many of you are familiar with those. You know, we mentioned Addison's disease, autism. We talked about earlier that sometimes that there can be a misdiagnosis. This is one of the issues that we deal with is sometimes these disorders with psychotic symptoms are actually what may be the person has, and this may be a situation where they are, get misdiagnosed. Why do you think there is the misdiagnosis with these diseases? Well, one of the things that can happen is that sometimes we talk about force-fitting a diagnosis into your practice. The same thing can happen is that people can, Rebecca, you mentioned a good point there, is that basically the person may actually not be, the term qualified to diagnose, that is that can raise a lot of hackles, when you use that. But reality of it is that they would argue that if they have an MD, they are qualified to diagnose. I think that there is an issue of where someone has not had that much experience or may not take the amount of time they respond. They respond to what the patient presents with and focus in on that symptom rather than looking and doing a complete workup. There are biases. Geraldine, as you mentioned there, one of the things that happens is sometimes the bias is that they may have a bias as that's the disease they want to treat. Sometimes you got to think about a bias where someone is my experience has been sometimes is that a person would much rather have a bipolar diagnosis than a schizophrenia diagnosis. I don't know if you've seen that. A big part of it, Brady, is what you've talking about is very poorly taken history because, looking at a lot of medical records, the things that that I see a lot of times is that that when they're going through the review of symptoms, when they get to the psychiatric or mental, that is pretty much limited to if they're alert and oriented times 3 or 4. Going into anything else usually is either not the time or they just don't have the inclination to do it. The time is an issue and really a misunderstanding. It's talking about lack of education is that you realize that you guys get much more education with regard to the diagnosis of these diseases. Plus you have more real world experience. Sometimes a physician, I think, or a treating physician may not come up with a diagnosis because it may be more of a difficulty to deal with. So they go with treating a symptom rather than a disease. But any of these diseases, a couple of them that a few of them I've got in red that tend to show up quite a bit. Bipolar disorder sometimes can have psychotic presentations. The mania may sometimes look as if it is psychosis. Cushing's disease. Cushing's disease is a little bit easier, but you can have somebody that has Cushing's disease with comorbid schizophrenia. Dementia, two things with regard to dementia. Let me just mention this one here, which is a very common thing. And I've known several people that have had dementia personally. And one of the issues that comes into play is that older people that get to that age of dementia, and especially, we're getting people that are showing with dementia in their 50s and early 60s, whereas we used to think of dementia as being a little bit further on, is that a lot of people starting to get in their mid 50s to 60s that schizophrenia may just simply be it may be truly schizophrenia, but people just associate that with potentially emerging dementia. So again, that's one of those things that it's an easy default diagnosis is if they're getting old. Then the other issue is that dementia is not going to have the treatment modalities that you will see with schizophrenia. We do use some antipsychotics with treating dementia, but a lot of people, it's easier just to accept that this is an aging issue. The other thing is, like, it's not in red, but I've got cancer. It's one of those things where that we will sometimes, depending on the cancer, is the individuals will just dismiss the schizophrenia and just simply will say it's where the cancer spread to the brain or something along those lines. I've got syphilis listed here. Surprising, there's a lot of people that do not think syphilis still exists, or that syphilis is in just in certain socioeconomic groups, lower socioeconomic groups. But syphilis can definitely have it. And then thyrotoxicosis, thyroid disease is that's fairly easy to diagnose. So again, part of the rule out or differential is going through these particular situations. Now, we talked about this next few slides, and so I'm going to move through them a little bit quickly. And we're going to talk about some issues, just sort of touch on them. But one big thing is we do see schizophrenic patients do when we're going to see it in bipolar. Both groups of patients have a potential to use substances of abuse. So a couple of things that come into play is one, they're using some of these substances to self-medicate. Another thing that we are seeing is sometimes the comorbid conditions are there. I mean, that had existed, and the schizophrenia emerges on top of it. So one of the things is we always want to be aware of this. And when we look for drug abuse, these symptoms or potential indications, these do not diagnose. I get a lot of calls with regard to, especially with legal cases, get a lot of calls with regard to looking at potential signs of substance abuse. These slides should you should recall them because we did look at them in the physical assessment course. So things that we see: bloodshot, watery eyes. People get this because of the irritant actions of for example, smoke. They're smoking marijuana, if they're taking other things. The other thing we've seen, have any of y'all heard of eyeballing by any chance? Eyeballing is, all right, so basically what eyeballing is there's this, started in England, and it's where people are, the perception is that the mucous membranes of your eyes will absorb faster than other. And so people are like pour vodka in their eyes to try to get drunk quicker. So that's called eyeballing. But we see, bloodshot, watery eyes, sometimes with overuse of stimulants, they're not staying awake. Sometimes they're not being able to sleep, so they're staying awake. But the other thing is, bloodshot, watery eyes, alcohol does it, marijuana smoke can do it. Sometimes from smoking, meth or even crack, that can occur. But the reality of it is that we can't use that as the only thing. That's why I said on these next 3 or 4 slides, I referred to them as potential indications of drug abuse. Looking at the pupils, dilated, very dilated or constricted pupils that are not considered appropriate. So if I'm in a very brightly lit room, I don't expect my pupils to be extremely dilated. On the other hand, if I'm in a very dimly lit room, I expect dilated pupils, not very constricted pupils. Bad body or breath odor. One is that a lot of times just oral and physical hygiene becomes becomes not important. Some of the drugs, they either when they're going through withdrawal or while they're on them, they will emit a body odor. Excuse me. People have described, just like sweaty body odor is one thing. Sometimes you may smell some people describe it as like cat urine is an odor. Is anybody else, some of you I know have worked with substance abuse patients. Any other odors that you pick up that seem to be unusual? Sometimes you'll smell some of the, if they're making or cooking, their own drugs, like with meth or something like that, or they're doing, using some of these chemicals, you'll pick that up if it's on their clothing. Maribel, you mentioned meth odor. How would you describe the meth odor? I'm just curious. Sort of a chemical smell. With the meth odor, some of our police officers describe it as sort of an organic smell. Some of them describe it more as a cat urine or stale urine smell. We also have people that, when they're doing drugs is basically, they may be incontinent a little bit and they wet their pants or not paying attention when they go to the bathroom. So they, pee on their pants and stuff like that. Um, the breath odor typically is going to come from a lot of times, again, poor oral hygiene. Another thing is a lot of stimulants will dry the saliva up so that you don't have the good washing of the mouth, and then they also may eat a lot of sweets, which can cause tooth decay. The nature of the skin is another thing that we see. We find that the um, the just general skin appearance is like they look sick. Um, that's true, Rebecca, is we do get the meth mouth. I forgot to mention that. So the rotten teeth and the discolored teeth. Um, the um, uh, the skin will look really like it doesn't have a lot of tone to it. A lot of times we'll see skin boils or sores where they pick at it, where that they get infected. Can also see injection sites become, tracks get infected and scars that form. These are common things that we see. Um, these other things may come from people that know them, uh, where they may have unusual extremes. So we may see they may be crying quite a lot or laughing a lot, which is often um, inappropriate at the time, or it just seems excessive. Um, little thing just gets them cracking up or gets them to just crying. Being very anti-authoritarian, arguing, argumentative, things like that. Now, we all know there are certain people that aren't using drugs, that's just their nature. But typically, someone that knows them real well will see that this is way out of character for them. Being overstimulated, just where they're just restless, they can't seem to want to sit down. Um, Maybe making a lot of repetitive movements, um, spinning a pen in their hand, flipping coins, or moving things around. Just it's almost like they can't relax. Or we may see that they're constantly sleepy. They just can't seem to keep their eyes open. And sometimes we see the both ends of the spectrum is that when they're on the drug, we may see them just ramped up. And other times what we may see is that they just can barely keep their eyes open. The thing that's interesting now is, I don't know if you guys have seen, there's a number of ads that are out that are describing the narcolepsy, about, people keep falling asleep during the day and all this other stuff. So anytime we see this barrage of ads coming out, it always concerns me that we're going to suddenly start seeing individuals that um, basically start taking that as their diagnosis. So those are some things. And changes in appetite, either they're really hungry, ravenous. Many times when they're ravenous, they want sweets and liquids. And then that can go to a state where that they're just not hungry. A lot of the stimulants will actually suppress appetite. Typically, we see a lot of paranoia that can occur, but realize with schizophrenia, paranoia is one of those things. They can be very suspicious. They can be sometimes hypervigilant, convinced someone is after them, convinced the police, convinced that, if you're talking to them, that you may be working for the CIA or the police or the Bureau of Investigation. Generally, we will see also over the period of time, a general deterioration of their just overall physical health. The sad part about it, usually in substance abuse, we see that deterioration usually occurs, is one of the last things that deteriorates. We usually see, a lot of other aspects of their life affect, and that's one of the things that gives them this false sense of security, or false sense that they're well, they're not sick, they don't have an abuse problem, is because they are their physical health has not deteriorated. On the other hand, when they go into rehab, their physical health recovers pretty quickly compared to their mental health and, emotional health and so forth. And a lot of times they think they're cured, and so they want to leave very quickly. But things we look for is just their overall body tone, how they carry themselves. The skin color a lot of times will get very, very pale, pallid. The way they stand, they're just not carrying their body. They may have typically we see a loss of weight in these individuals because they're using the drugs and they're not, the nutrition. A lot of times they can become sort of malnourished and sort of ill looking. Mental health in general, we're going to see a lot of things, paranoid behavior, emotional extremes, things I've touched about before. They can become apathetic, dull, unresponsive, poor job performance, things they were interested in, those just don't seem important to them anymore. Even personality changes. A lot of their moral issues may actually change. Their former values they thought were very important have been replaced. Their main focus is to try to use the drugs, and then sometimes they get some really abnormal ideas and ideals. So I had an interesting report from a student this last week, which is just, it floors me, is one of their classes, the professor went on about mental health is just made up by the government, that that the government has convinced people to take drugs because it's a way that the government controls. I just thought it was way inappropriate. So my concern with this, and I've suggested to the student to maybe go talk to the professor's department head anonymously, because I just think about, this is one of those classes. It's actually I think it's a sociology class or something, but anyway, it's just, I can just imagine that there's probably 30 to 50 students in there, if not more, and I'm sure that there are some individuals that are probably on medication and would hope that somebody like that would not do that. But Arnold, I thought the same thing as I was sitting there thinking, it sounds like, as I told the student, I said, it sounds like he's just become the poster child for mental health the way he's been talking. So that's one thing that scares me sometimes in university systems, is that I used to tell my wife, she worked as a kindergarten and elementary parapro, and I said, I think it's interesting that you have to have a teaching certificate to teach first, second, third, fourth graders and so forth like that, and then people teaching our healthcare professionals do not, other than having your degree, they don't have to have another, it's not, they have their professional degree, but as far as having a certificate to show that they're capable of teaching, that's not necessarily the case, and it's a little scary there. But these other tests, again, these should be a review from what we've talked about in general. And so one of the easiest things to do is to do a drug test. And with the drug test, you can do some of these in your office. You can do these screens very easily in your office. Again, one of the things that you have to look at is, first thing I will tell you is to make sure that when you're doing a drug test is that there are a number of drugs that people use. And one of the things, if you look at what SAMHSA basically recommends and what we frequently get at the hospital for a drug test, it's pretty pathetic, seriously. From the standpoint of it is, you can do these emit tests. You can purchase those and do them pretty cheaply in your office. The problem you run into is what I was getting around to, is that you got to know what pretty much what your patient population is using, because the students I shouldn't say students, even though some of the students know it, but employees and stuff like that, people are using drugs. one of the big things that they've learned to do is they have recognized where to go get drug tested or what drugs to use that will not be picked up on the um, on the drug test. So for example, in the hospital, they run at least a 5-panel test. They do amphetamines, amphetamine-like, they do barbiturates, they do cocaine, cocaine metabolites, they do THC, they do benzodiazepines, and I think they do opiates. Okay, so if you look at the benzodiazepines, it says some benzodiazepines. It will not pick up all of the benzodiazepines. When you look at the opiates, it will not pick up synthetic opiates, the typical test. So one of the things is that it's very easy if you're just doing a straight test. If you're a drug user, a lot of times it's fairly easy to beat a test. So simply because the test is not. So for example, if I'm doing fentanyl, it's not going to show up on I can go to the hospital and it's not going to show up. So the bottom line is that we have to know what we're testing for. And so remember that these tests right here, the EMIT and the RIA, the EMIT is the most commonly used. It's the fast screening test. TLC is thin layer chromatography, and we don't use TLC very often anymore. It's time consuming. This is, if you took a chemistry class, is where that you basically put the solution of the chemical in the bottom, and then you stuck the little, it was like a glass plate that was coated, and then you would let it sit overnight, and then it would go up the plate, and then you would compare it to standards. But typically what we're going to see used on most situations is going to be the EMIT test for the screen, and then we're going to see the GC mass spec for the confirmation. So the EMIT, it stands for enzyme modified immunoassay test. And what we look for is the EMIT test will not quantitate. Basically what it does is it will tell you if it's positive or negative. And if it's positive, they usually refer to it either as positive or indicative. If it's negative, a lot of times they just call it negative, okay? Typically what's going to happen is we do the test. If the test comes back positive, which basically there's a cutoff screen on the particular test. So if the cutoff screen is, say, 50 nanograms per mil, then theoretically, if that person has 50 nanograms or higher, it will show as a positive test. If it's 49 or lower, it would show as a negative test. So if it's positive, then we will send that same sample for confirmation, usually to another lab, GC mass spec. A lot of the people that do it in their office around here, I don't know how many of you guys do drug testing in your practice, but a lot of the people around here will run the screen in their office and then have a relationship or a contract with another lab that will allow them to carry that and have it tested there. If people beat the EMIT test, I mean, people say they beat drug tests, this is the one they beat. This is the one that is, that's why we never just use this by itself, because there can be false positives. So a lot of people that I get called about, a lot of times they are trying to convince me, or they have told whoever is testing them that, you know, like I'm dealing with a case right now where I really am perplexed, where we have a woman that is no incidents whatsoever of methamphetamine use. She is not the person. She's, you know, everything. There's nothing that suggests that, but she tested positive on a methamphetamine screen, and it's confirmed. We even have a lot of clinical, you know, when they were taking the test, we had some clinical things. There is no evidence whatsoever that she is on methamphetamine. It's sort of like one of these aberrant lab tests. But we all the time have people like with methamphetamine saying, oh, well, I took a cough cold preparation last night, or I took Sudafed or something like that. So we do see that sometimes that there are things that can produce false positives in these screen tests. So the idea is that, and if we think somebody is trying to beat the screen test, then one of the things that we're going to try to do is we're going to basically, I usually suggest go ahead and send it for confirmation, because I've had over the years several instances where we were pretty sure someone was beating the test, the EMIT, and we have found by sending that sample off, same sample that showed a negative, we found that it pretty much turned out to be positive. All right, let's see. There we go. The RIA test, this is a radioimmunoassay, still a screen test. It is harder to beat than an EMIT test. Typically, this is used by the military and sometimes police. A lot of them still use EMIT. I don't know. Have any of you that are doing drug testing? Have any of y'all had any of your people that have been use the RIA test? The VA sometimes, I've seen some VAs use it, but it's even with the RIA, it's more expensive. It uses a radioisotope. Typically, if you get a positive, you're going to send it for a confirmation test too. But these immunoassays, whether it's RIA or the EMIT, basically really is our only practical tool for dealing with large sample sizes. They can turn them around pretty quick. They're relatively inexpensive. You can run them because pretty much it's putting urine on a, it's sort of like a pregnancy test. You just get a urine sample and put some in on the thing, and then it pretty much will show whether it's a positive or negative. When we're looking at the drug testing, the things that we are trying to come across is, what else will this drug test cross-react with? How specific is it? The cutoff levels, you can buy, different tests may have different cutoff levels. For the hospitals, these are determined by SAMHSA. Some of these tests will indicate if there's been adulterants, things put into the urine to try to mask the test. Some of these things will list that. So that is, some of these drug tests will actually tell us that. And then, like I said, the GC mass spec is usually our confirmation test. It is basically the GC mass spec is very expensive. We usually have minimal people that, for example, in the laboratory, it's not uncommon for there be one technician or two technicians that use that particular machine. You don't have people come in and out, a lot of different people using it typically. You have a very select number, they're highly trained. They're responsible for making sure it's calibrated and all this other stuff that goes through. But it pretty much gives us the fingerprint of the test. The only issue with GC mass spec is that if there is sometimes an interfering substance, we may get some problems with the peak, but it's pretty easy to see. And but it's very specific, and not only will it tell you whether it is the methamphetamine versus the pseudoephedrine, but it will also tell you how much. I don't know if any of you, when you get, what's it called? Get drug test resorts. I don't know if any of you get drug tests from, some of you probably get them from places like NMS, but if you get them from your local, here it's GBI, whatever your state crime lab is, sometimes they will do a confirmation test, like I see frequently, something like gabapentin. And with gabapentin, they will often just give me that it's confirmed gabapentin, and they don't specifically say the amount there. So many times we get it, and it's pretty much confirming that the drug is there. You will see that sometimes with things like some of the antipsychotics and selective serotonin reuptake inhibitors. Sometimes you will see where there's a value. Sometimes you will see it just confirms that it's there. if you're getting them from one of the commercial labs like NMS, forget some of the other labs that are used, but anyway, those will typically report the value. If they get a value or if they confirm it, they will typically give you a value. So what can be tested? Obviously, with alcohol, we do have the breath test. Personally, when I'm dealing with alcohol issue, we will, like for example, if it's a DUI or crime type thing, they will possibly show a roadside sobriety or roadside alcohol test where they do a breathalyzer on the road. That is interesting to see, but on the other hand, many of the courts will not allow that to be used specifically as evidence. But what we find is that the one that they do with the Intoxilyzer, which is a typical machine, is that one is used as long as it's calibrated correctly and everything else like that. Personally, if I'm looking at blood alcohol, I prefer looking at the GC mass spec. That to me is the more direct. Now, some of you may get blood alcohols that come from the hospital. Okay. The hospitals do not use GC mass spec to do their blood alcohols. What they typically do is they use an indirect assay. It's called the alcohol dehydrogenase assay, which is basically a solution. And the idea is that when the blood is mixed with the solution, which has alcohol dehydrogenase in it, that it generates a signal due to the formation of, I think it's NADH, if I'm not mistaken. So it's an indirect assay. And they will report it typically. It's not going to be reported in grams per deciliter, which is usually what we look at. So it's usually reported in grams per mils or something like that. So you have to divide that. So if it comes back as 139, then it would be equivalent to a 0.139 blood alcohol. The problem with that assay is that it is, if there's a lot of lactic dehydrogenase or lactic acid that's present due to, like, for example, some extensive trauma, which there's muscle damage and so forth, then those two compounds may produce a little bit of interference. Typically, what most of you are going to look at is urine or blood. And but we also have used hair. I only see hair being used primarily for date rape cases and child family services. Saliva we see used occasionally in, they will do like a little under the tongue dipstick to, these are more screening tests. I don't think they're extremely accurate. We do use saliva quite a bit for measuring nicotine. So if you're looking at somebody stopping smoking and stuff like that. And then, one of the other things is level impairment. So so you looked at cortisol in trauma survivors. Do you know, Eddie, how long the cortisol is viable, or how long you can pick that up? On most of the stuff that I see with the other testing and everything like that, typically what I'm looking at is you can pick up drugs of abuse up to about 90 days. So within the first month, yeah. Okay, cool. Going through this testing real quick, typically when we're doing when you pull blood, pretty much, if you're going to use it for legal issues, you need a chain of command, chain of custody. You need to make sure everything is there. But what will happen is on urine samples, which is our most common means of testing, is basically we take and the lab will have what is called a blind sample or a blank. So that's what they'll use to help calibrate their machines and things like that. And what we find here is that that's going to be at the lab. So they either have one that's certified that it has no drugs in it, or we see that they have it spiked. So they will have, you would know pretty much, what is, for example, I would have samples of urine that was spiked with 5, 10, 25, 50, 100 nanograms. So that would be my standard curve. But that's what's going to be at the labs. But what we typically are going to do is we're going to get the urine sample. We'll split it up into 2 separate bottles. If we're doing blood, we just pull 2 tubes of blood. For the urine, we typically need about 45 to 60 something mils. That can occur even if somebody has emptied their bladder. We find that is still plenty of time to, still plenty of, most people can generate that much there. It's not 2 different voids. They're collected at the same time. It's collected at the same time as a single sample. You've got one as a backup, which if something happened to the first one, you can follow it. That's sealed in the presence of the individual. In the blood, when that's pulled, that's usually in the presence of someone else. Those are put with tamper-proof seals, stuck in what we call a secondary seal, which is nothing more than a leak-proof plastic bag. So pretty much like a Ziploc baggie. And that's just to make sure if it spills in transit to the lab, it doesn't mess up anybody. The shipping container that carries to the lab is sealed. It's put with a tamper-proof seal. One of the things we run into sometimes with bloods is sometimes, for example, with if the police have carried somebody to the hospital to get a blood draw, we have had on a few instances where the police officer has stuck it in the back of their patrol car and it stayed there unrefrigerated for 24, 48 hours. Typically, the blood will turn putrid. But we've also had sometimes, then this has gone to some of the national labs we've had where the blood was just stuck in a refrigerator, wasn't frozen. Same thing with urine. So this is shipped to the lab. There's a chain of custody. Everybody that touches it throughout the life cycle of the thing is basically going to sign this chain of custody. If you go to the freezer and move it out of the freezer while you're hunting for something else, you have to sign it. And then anything that produces a potential fatal flaw, anything that produces an error which raises doubt about this specimen, that basically would consider a fatal flaw, which means that we can't be sure that this drug or this sample hasn't been adulterated or hasn't been, that there's been swapped out or whatever. When the report is done, the medical review officer, they don't really interpret the lab results. What they basically do is sign off on it. And the interpretation really falls to typically whoever it's being sent to. Basically the interpretation is the officer will potentially say it's a positive sample and here's what we picked up. It's a negative sample, this is what we picked up. So there's some issues that come about with regard to exactly what the MRO does. Pretty much it's the licensed physician that's signing off, verifying it. With regard to the freezer, typically they're in a -80. If, worst case scenario is that just put in we've had them sometimes kept in the freezer of a regular freezer, and as long as they stay frozen, they're usually okay. Typically, unless the blood or urine putrefies, what will happen is for the person is it actually, typically if there's putrefaction or some weird thing that goes with the blood, it's hard to interpret those results because we know that there's been some changes. But just from a sample being put in a refrigerator, typically many labs will keep them for 6 months. Some of the crime labs will keep them up to a year unless you notify them. But we also have sometimes, like the lady I was telling you about with the methamphetamine, for whatever reason, they ran the sample and threw it away. So we don't have a backup. And that's created a little bit of a problem. The -80 freezer is pretty good. Typically, the longer they're stored over a period of time, you will start getting a loss of those, basically it's broken down. But typically for a year in a -80, they usually do pretty well. All right, let's take our last break for today. Let's come back at 5 after the hour. And
Doctor, I will run the poll to the attendance for right. Yeah.
Okay. That sounds good. Well, let's come back at 10 after the hour because you guys got a short break last time. Let's come at 10 after the hour, run the poll, and then we're going to finish up urine collection, drug testing, and a couple of other things. Again, since we've talked about this before, and it's just should be more of a review for you. When we're collecting the urine, we want to look for observation. So we want to see it go into the cup. One of the things you guys need to be aware of if you're doing these tests is they can be very, you really need to look and watch the urine go into the cup. Many of you in a practice situation may not be able to do that. That's always a chance of concern with regard to people beating the test. I've seen this in numerous ways that they can do it. We're going to look at the color of the urine. We're going to, theoretically, it should be clear to a yellow. We do see a lot of people with normal urines that, because they're drinking a lot of water, that their urine is fairly clear. So that's not an uncommon thing. We're going to look for temperature to see that the temperature is basically body temperature. And then also volume. One of the easiest ways that people try to make a case for the not doing a test is that you're watching them. We refer to that as a shy bladder. And that is typically they want to try to buy some time to try to avoid that. Basically, they're trying to get their urine test to go down. If you go on the internet, this is one of these things that sometimes is worth a perusal every now and then. There's a lot of different ways that are posted on the internet specifically to try to how to beat these tests. The reality of it is some of these have worked because of, again, either the testing has been somewhat lax in how it's been set up or observed. But there's a lot of things that are on the internet that actually have never beaten a drug test or would not beat one that's properly done. But this is an example of one, just to give you an idea. One is there's a couple of things. One is dilution method, which this is the old one that everybody tries to do, is that you find out when you're going to do a drug test. So between the time you're doing the drug test and between when you find out and do the drug test, is you just drink lots and lots and lots of fluids. The idea here, and sometimes they suggest taking diuretics. The idea is to try to flush your system out so that you're below the cutoff value. Most of the time, they're going to try to, if at all possible, to avoid morning urines because you pretty much stored it up and it's become concentrated, so you're more likely to test positive in the mornings. Sometimes in the past, we used to see when people would come in with a urine that was pretty clear, it was thought to be simply due to for them taking doing the dilution method. But so what people are doing now is they're adding vitamin B2 or a vitamin B complex that has B2. If you've ever taken a vitamin B2 complex, you know that, or a vitamin B complex that contains B2, you know that that'll turn the urine yellow. It tends to turn the urine more of a fluorescent yellow than like the normal urine color. And Eddie, there was a pill pack and there's a lot of things on the internet that sell that you can beat these tests, which some work, some don't work. Substitution of clean urine, that's called doping. You can buy powdered urine and reconstitute it, or we've even had individuals other people's urine. And like I know one instance where there was a woman that needed to pass her drug test. She was getting hired for a job. They told her to show up at 9 o'clock. She got some urine from her friend this woman occasionally smoked marijuana. and she got some urine from her friend and was able to put it in a tube, carry it underneath her, stuck it between her breasts to keep it body temperature, and then poured it into a cup there. Hold on just a second. I've got a dog that's having a big issue. Let me. One of our dogs I thought was outside, and he was trapped and was going through a major breakdown because of the vacuum cleaner, which he is. I think he suffers from post-traumatic stress from the vacuum cleaner. So I couldn't figure out where he was, and he was trapped between the vacuum cleaner had been left out, and he was trapped between there. So I thought he was going to need to be medicated. But so the thing is that the doping is a fairly common thing. But again, if you're doing the test right, then they should not be able to bring clean urine into the testing area. Adulterants, a lot of different things you can buy, but what a lot of people do is basically get powdered bleach, powdered detergent. They pack that in their fingernails, and then basically they urinate or put their fingers in the urine sample. And the concept is that the detergents interfere with the immunoassay. That's why some of the more common tests now will basically test for adulterants, and it'll flag it. And the way we deal with either if they can't get enough, give us enough urine, or that there's an adulterant, is we consider that as a failed test. And that's what a lot of facilities just will do, is they will just simply, make that statement. If you can't give us a urine, you miss your appointment, or any of that, that is considered a failed test. There's a product called Urinaid. The Visine can cause some diarrhea. One of the concepts is with the Visine is that the Visine and vinegar and things like that theoretically changes the pH of the urine, which would help get rid of some of the drug, or maybe interfere with the test. Niacin is the B2. Golden Seal has been around for ages. A lot of people swear by Golden Seal. We don't really know exactly how Golden Seal theoretically works. One issue is that the Golden Seal has a diuretic property, and as a result, basically the individuals as a diuresis help get rid of the drug. Some people argue that that the Golden Seal can interfere with the drug binding in the assay. So not really sure exactly why that is occurring. The other thing about drinking Visine is that if you think about it, that's Visine comes in small bottles, so it is you typically have to drink quite a bit of that. But I have seen people try to down vinegar. I showed you guys this before. These are a couple of the things that people have used to try to beat the drug test. The butt wedge, by the way, I've heard is no longer available, but the Whizzinator is still available, and it's, people have used it. So the drug testing, again, from a standpoint of most urine, and especially urine, is if it is done properly, the way that our athletic and most athletic associations do it, if they're really serious about doing it properly, is pretty much, for example, with our athletes, they have to come in, it's a random drug test. So the best way would be you get notified like on that day that you have to report to wherever, to the nurse or to the medical facility, within 30 minutes or so, 30 minutes to an hour, depending on what the situation is. The observation is basically they usually make them drop their pants down to their ankles, and they have to have short sleeve shirts on. With women, they can't have long, they've got a long tailed shirt, it has to be pulled up. And they literally have someone that observes the urine leaving the body going into the into the container there. The other thing that people would do, Eddie, would be is they slip phenolphthalein. That's an indicator that they use to touch for acid base. And what they've done with that is by slipping it in their drinks. We've seen this at pool parties. The person gets dumped into the pool, and then if they urinate, the phenolphthalein turns the urine a different color, so you get a cloud around you, and it can cause diarrhea. I saw that happening at when I was at Auburn. So if the test is done correctly, it's done as a random drug test with full observation, followed by a confirmation test. It is very, 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 very difficult for someone to beat that. So when we have people that are beating the test, typically it comes down to where that it is not being observed and people are able to bring clean urine in and so forth. Okay. The other type of testing that we've seen used is hair analysis. The big thing is a lot of people thought it was going to be the answer to not having to watch people pee in a cup. To pull the blood. The idea is you clip somebody's hair, takes about 60 hairs, which some people suggest is about the thickness of a pencil. I think that's probably, it's not quite that thick for 60 hairs. Typically, the testing around here is they use 90 days, so it'll detect drug use. It is expensive, more expensive than the other drug testing. We can't pick up recent use. So, for example, if you used an hour or so ago, it's got to have enough time to get in your hair. And this diagram you see is basically showing that the yellow molecules would be the drug. So it's the hair shaft is got some blood supply to it, and so it gets deposited in the hair. It's not sensitive for low dosage use, and what it's usually primarily used for is long-term use. So if somebody, theoretically, if someone used and we're past the window for the urine or blood test, say it's more than 72 hours or so, we might want to consider doing a hair. As I said, this typically shows up in DFACS cases to find out if the parent or guardian has used drugs within the last 30 to 90 days. Okay. All right, let me cover this slide, and this will be a good place for us to stop today. When I finish this slide, then Aiden will put the quiz up for this afternoon, and then you guys have got the 4 videos to watch tonight. The other thing is, if you would look back over in preparation for tomorrow, the slides dealing with the 4 pathways, the 4 dopamine pathways. So it is going to be, that's something we're going to spend a lot of time on tomorrow, is looking specifically at those antipsychotics. Arnold, let me answer that question for you because I meant to mention that. So people have shaved their head to get around the drug test. You can use hair, you can use body hair, pubic hair, underarm hair. Even with that, we still have people that will do like a completely shave themselves down. If that is something that they immediately did, it's highly suspicious. But typically we can get some body hair. There is a concern with regard to there may be some ethnic differences in how the drug is deposited in the hair. But again, I think from a standpoint of if you're using it for the limitations that it should have roughly just to see if there's been drug use, then you should, okay. Now, tomorrow we're going to really start into the different drugs, and we're going to go in detail with the various different drugs, and it's going to build upon what we've talked about today, which is we've laid the foundation for how these drugs work, and we're going to look at how these drugs work. We're going to look at their side effects and so forth. So one of the things that comes into play is that when people have schizophrenia, and this is for any disease really, the question is deciding when to treat. And it's a no-brainer when you're talking about someone that has, very extensive symptoms and creating major issues. The biggest problem we had from a standpoint is really that the antipsychotic drugs we had in the past were not pleasant to take and had a lot of side effects, and sometimes the side effects really limited to how much we could treat these individuals. So what we do know is the antipsychotics, which is when I've abbreviated them AP, they are effective for treating psychosis regardless of the diagnosis. So we do know the antipsychotics can be used to treat psychosis, and that psychosis may be due to some other factor other than schizophrenia. Okay. What we want to do is we have to look, and one of the big things is to make sure that maybe we treat initially, but one of the big things that we're going to try to figure out is is there something else that's causing the psychosis? We need to treat the primary cause there. But the other thing we need to do is especially medication toxicity, because you're going to get patients that's coming in and they may be dealing with either a compliance problem where they've taken too much or taken it wrong, some medication, which therefore you may treat the psychosis and then correct that. You may have somebody that's dealing with substance abuse, and you need to be aware of that. So when we're using an antipsychotic, we should make sure that there's clear evidence of psychosis. We have seen people that come in and bring somebody in and say they're being psychotic and so forth like that, which may not be there. A colleague of mine made this statement, and I like it. I like it from a pharmacological standpoint in general. Try to find a reason not to use an antipsychotic drug. The basis of Clue's reason he used to say that was, if I try to rule out why I should not use it, then I have ruled out the reasons and made sure that I do need to use it. And this was especially true when we were dealing with some of the conventional agents. Okay. Another big thing he and several other people used to preach is don't use an antipsychotic as a sedative. We see that some of these antipsychotics have pretty good sedative properties. So if we need a sedative, then let's use a sedative. But let's not, the antipsychotics being used as a sedative can create problems. Their side effect profile may be worse. So again, we want to make sure we need one. We know that they will be effective. But, one of the things is if somebody comes in with psychosis that may be due to medication toxicity, well, we just added another drug on top of their regimen there. So instead, use it to, treat the initial psychosis and then figure out that it's something else. And by correcting that, then we don't need to use the antipsychotic. So this is what we're going to talk about tomorrow. We're going to talk about how the drugs, I'll go over the test of these questions that you guys are going to do in just a moment. And I'll go over the questions, first of all, in the morning. And then we're going to spend most of the day, and probably you'll have one or two case studies to work on tomorrow. I'll probably try to give you a case study at the end of the morning session, and maybe one mid-session tomorrow afternoon. Aiden will make the quiz available. Does anybody have any questions before I let you guys go? All right, good luck on the quiz. And again, we'll go over those in the morning, and make sure you look at those videos. They're very short videos. I don't think it'll take you more than about 10 minutes to watch all 4 videos, but it talks about the glutamate thing. And then if you would just look over those 4 dopaminergic pathways one more time. I will go over them again tomorrow, but it's going to really help if you guys have a good understanding of those. Okay. Okay. Now I'm going to sign off here, and if you'll go ahead and put the quiz up.
I'm going to run the quiz
right now. I will log in tomorrow morning at the same time. Okay.
Awesome. Awesome. Thank you.
All right.
I'll
You
keep
guys have a
the
great
poll
evening.
running for 10 minutes.
Sounds good.